Hi, I'm Dr. Carl. Welcome back. Today we're going to discuss paracetamol overdose. The dangers of paracetamol overdose are numerous. The patient's presentation may be inherently ambiguous. There are many mistakes besetting the treating clinician, and our hospital systems and wait times heighten the risk of misdiagnosis and error. As such, stay sharp as we do a deep dive into this important topic. Paracetamol is the most widely used over-the-counter analgesic in the world. Paracetamol overdose is one of the most common reasons for emergency hospital admission. Around 100,000 people present to the emergency department in the UK each and every year with paracetamol overdose. Around half are admitted for antidote therapy with acetylcysteine. In 2021, there were 200 deaths relating to paracetamol poisoning. Intentional overdose with paracetamol is increasingly seen amongst young people. Most cases in the UK are impulsive acts of self-harm. Paracetamol overdose can be associated with hepatic failure and death. Although rare, paracetamol overdose remains the leading cause of acute liver failure in the Western world. So, how does this over-the-counter medication cause such trouble? Let's consider what happens when a person takes a therapeutic dose, that is to say, a safe dose. In this context, 95% of the drug undergoes glucuronidation, a form of metabolism, to create a water-soluble paracetamol conjugate that is eliminated out of the body in the urine. The remaining 5% of the drug is metabolized using cytochrome P450 enzymes to a toxic metabolite called NAPK, N-acetyl-P-benzoquinoneimine. A small amount of this is something that the body can deal with. Typically, NAPK binds to glutathione, another protein in the body, to become a mercapturate derivative, a non-toxic metabolite that also gets excreted in the urine. In overdose, there is a significantly larger amount of NAPK produced, and this can significantly exceed the body's detoxification capacity due to the finite amounts of glutathione available. As a result, the excess NAPK binds to the hepatocytes and can cause mitochondrial injury, and in severe cases can lead to acute liver failure and even death. It is known as the silent killer, as there are not always symptoms. Clinical features are highly variable and depend on the ingestion method, the time from overdose to presentation, the amount of paracetamol taken, and the pre-morbid condition of the patient. When symptoms do occur, common symptoms include nausea, vomiting, lethargy, and pallor. Note, if combined with other drugs such as opioids, in the example of cocodamol, a concomitant opioid toxidrome may be present, and related symptoms may then occur. Clinical symptoms in the context of paracetamol overdose may give a clue to the amount of paracetamol taken, and also may give a clue to when the paracetamol was taken. In the first 12 hours, symptoms vary, but may include the person being potentially asymptomatic. They may have nausea and vomiting. They may present with mild, moderate abdominal pain and tenderness. This first stage, where there is a general malaise, perhaps with nausea, vomiting and abdominal pain, can also be largely silent for the first 12 hours. LFTs may also be normal and falsely reassuring in this time. After 12 to 36 hours since the overdose has occurred, moderate severe abdominal pain may occur. There may also be clues such as metabolic acidosis, a high bilirubin and jaundice, acute kidney injury, confusion and hepatic encephalopathy, coma with reduced conscious level, and indeed bruising or systemic hemorrhage as a consequence of coagulopathy secondary to the impaired hepatic clotting factor production. At this point, laboratory tests start to change. At 24 hours, expect a transaminitis and possible coagulopathy. Look for the early clues of liver damage. At 72 hours, things are progressing. There may now be features of hepatic failure that are significant. Jaundice, coagulopathy, encephalopathy, and hepatorenal failure may be occurring. If the patient isn't treated, by 96 hours, there is either a recovery, as in the person survives, or the liver failure progresses to death, sadly. Not all patients are the same. Some are more vulnerable to the toxic effects of paracetamol. Those with pre-existing liver injury, those with other medications which can influence how the body responds, and those with lower glutathione stores, for example, as a result of malnourishment, an eating disorder, past alcohol misuse, or chronic illness, all have a higher risk when it comes to the toxic effects of paracetamol. So how can we anticipate whether or not a person has got a good or a bad prognosis? The following features in their assessment are very worrying: hypoglycemia, coagulopathy, lactic acidosis, altered conscious level, bradycardia, kidney failure or rhabdomyolysis, hypothermia or hyperthermia are all factors associated with poor outcomes in the context of paracetamol overdose. What makes things more complicated again is that not all overdoses are the same. It is useful to think of one of three scenarios when considering paracetamol overdose. 1. It may be a single recent paracetamol overdose with purposeful intent. 2. It may be a chronic supratherapeutic overdose over a prolonged period of time, be it staggered, intended or unintended. And 3. It might be a massive paracetamol overdose. Most paracetamol deaths are a result of either a delayed presentation after a deliberate overdose or the result of a chronic supratherapeutic overdose that has occurred accidentally, where the patient has taken medication of different types for fever or pain over several days. Once you've determined the type of overdose you're dealing with, you're then ready to proceed. There are certain thresholds of overdose that suggest harm is likely. Paracetamol-induced hepatic injury is most likely to occur after ingestions of more than 10 grams, or alternatively, more than 200 milligrams per kilo. Ingestions of greater than 75 milligrams per kilo are still considered significant and warrant further investigation. As we've discussed, there are different types of paracetamol overdose. When it comes to the treatment nomogram, the Rumack-Matthew nomogram, it is important to understand its purpose and when and where it can be used. Here, the x-axis represents hours since ingestion, whilst the y-axis represents paracetamol level and concentration in the blood. This graph was derived by plotting untreated patients with acute paracetamol ingestion. Above the line, the patients in the study developed hepatotoxicity, defined as raised liver enzymes, AST and ALT, above 1000. Below the line, the study patients didn't develop hepatotoxicity. The line was then lowered to be more conservative, with only 60% of patients above the line at risk of hepatotoxicity. In the United States, the line was lowered even further, whereby approximately 1% of patients above the line remained at risk. The nomogram should be interpreted in the very specific setting of a single recent overdose of regular release paracetamol. It should not be used if the time of ingestion is unknown. In the case of chronic overdose, staggered overdose, or repeated ingestions. It should also not be used when there is a massive overdose or a chronically supratherapeutic overdose. Also beware in the context of co-ingestion with other medication. If you are using it and the initial level is not above the nomogram line at the 4-hour mark, then an 8-hour and 12-hour level should also be drawn to be sure. If the initial level is above the treatment line, then repeat paracetamol levels are not needed, as treatment should be started. Treatment is called NAC, N-acetylcysteine. This is a highly effective antidote if used within 8 hours of the overdose. So how do we give it? Since 2021, the Royal College of Emergency Medicine supports the routine use of the SNAP regime. The position statement recommends the use of SNAP to treat paracetamol toxicity, and that it should become the default standard practice in all emergency departments. As per the Lancet publication in 2019, the SNAP regime has been shown to be as effective as the traditional regime in preventing liver injury with fewer adverse reactions. Indeed, the SNAP regime not only offers significant benefits to patients in terms of fewer side effects, but also reduced lengths of stay in hospital. Its implementation in children also reduces the risk of confusion relating to regime selection when dealing with adults versus children in a busy A&E. The implementation of the SNAP protocol is expected to reduce the length of stay of children as patients, as it enables them to be medically cleared sooner for mental health review. As we have seen, the treatment line in the right context is valuable in deciding whether treatment is needed. However, there are circumstances where NAC should be started immediately without blood test results. For example, if a single ingestion has occurred more than 15 hours ago, start immediately. If the ingestion is staggered, if the timing of the overdose is uncertain, or if the ingestion is greater than 4 hours ago and blood test results will not be known within the 8-hour window of treatment. Consider waiting for blood results before prescribing NAC if ingestion again occurred more than 4 hours ago and blood results will be known very soon, within 8 hours since ingestion. Indications for using this antidote, as discussed, include if the paracetamol level is above the Rumac-Matthew nomogram treatment line, i.e. it is a line crosser, after a single acute ingestion within 24 hours. It is also indicated if elevated liver transaminases are deemed to be the result of a paracetamol overdose. This is even in the absence of an elevated paracetamol level. And then lastly, the most important takeaway is that N-acetylcysteine needs to be given within the 8-hour window of the overdose to be maximally effective. Delays in prescribing and ordering and administering the NAC can cause lives to be lost. NAC should be a stat medication. Make this important to your team. Next time, we're going to look at clinical cases including hidden overdose, accidental overdose, chronic overdose, staggered overdose, overdose in pregnancy, and cases of massive overdose. In addition to this talk, do consider visiting the links in the description. The BMJ, the College of Emergency Medicine, and Life in the Fast Lane, as well as emergency medicine cases, have all written excellent guides to managing paracetamol overdose. Thank you.